Yes, please. Supadra, for Supadra. Okay.
So the question is, can we use, alternate to tropicamide as cyclopentolate? Yes, 0.5% cyclopentolate we can use. The disadvantage is that if the child has seizures, we don't use cyclopentolate, because some of these children would already have intracranial hemorrhage, seizure, so then you have to not use cyclopentolate in them. The other thing is, cyclopentolate sometimes can cause a lot of irritability, which is a idiosyncratic effect, although 0.5% doesn't cause that much. But 0.5% advantage of cyclopentolate is that the dilatation remains for longer time. So if you're going to a nursery where there are too many children, or you don't know what time you're going to go, and you have like 3-4 hours of window in which you have to go, because the 2.5% phenylephrine and tropicamide effect will last for about an hour or so, an hour or an hour and a half. But if you have like erratical scheduling, then you are telling the nurse, okay, you put the drops in the morning, and after, whenever I come, I can see. So, depending on your schedule. But we are using 2.5% phenylephrine. The pupil also dilates much more to phenylephrine, because it's a good mediatic, it's not a good cycloplegic. So in these children, we don't need cycloplegia at the time of screening. What we need is good dilatation. Okay, but yes, 0.5% cyclopentolate has also been accepted in our national guideline also, and we can use that. Yes, please. Yes, we can use 1% tropicamide also. So you can have separate bottles, like you can have 1% tropicamide, and then you can have the 5% phenylephrine, which is commercially available, diluted to half with lubricant. The 2.5% with 0.5% tropicamide is also commercially available in some countries. Alcon makes it. In India, it is available as Tropac P Semi, and there are 2-3 companies which are making it. Actually, for adults also now we have sort of stopped the 5%, because we have so many diabetics and heart patients, and they get problem with the 5%. So we are using 2.5%. So in some countries it is commercially available. Alcon makes it in US. So usually we say that use only 2 times, okay, along with Paracaine, because Paracaine will help it to go into the cornea faster, so its effect comes faster and stronger. So you put a drop of Paracaine, that is the topical and anesthetic drop, and then this drop, and use only 2 times. If it doesn't dilate in 15 minutes or 20 minutes, then start thinking that there is very severe ROP behind, or the drop didn't go inside. And of course, every time we put a drop, clean the skin, because it should not get absorbed through the skin or the NLD. Okay, keep on watching the pulse rate, the color of the baby. They'll really get flushed, so there's a lot of drug which has gone into their body. Remember, all the eye drops that we use, they're all meant for 60 kg adult male. Any eye drop in the world is manufactured for a 60 kg adult male. So just imagine a 900 gram baby getting 1 drop of that. How much dose is going into the body, whether it's tropicamide or it's antibiotic or steroid.
Thank you. Maybe later, yeah. So I will start my talk about international classification of ROP. Actually, Baran made my talk easier by giving the first descriptions of some of the classifications, but the main purpose of the international classification of ROP was to describe the internationally accepted, correct and common terminology to define ROP. And it was previously called retrolental fibroplasia. Probably you remember. It was published in 1953, and then since it was not describing the acute stages, the ICROP committee come together to define the terminology. And we have 3 ICROP committees, and the first one started in 1984 from different countries, 23 ophthalmologists, and they published the first paper, and this first paper described the distribution of the disease as zones and the extent of the disease in clock hours and the stages and the plus disease. So the basis of the main terminology stays there. So you know the zones which was defined at the beginning, like zone 1, 2, 3. Zone 1 was the central zone around optic nerve head with a radius of twice the distance from the disc to fovea. That's the most central one. And the zone 2 is the donut-shaped area around the zone 1 with a radius of disc to nasal ora serrata. And the zone 3 was the crescentic area left in the temporal periphery. And when you see the 2 clock hours in the nasal aura as vascularized, then you say that its zone 2 is vascularized. And when we check it in a real montage picture of fundus, this was the zone 1. It's easy to see it in the temporal part. In the nasal part, sometimes it may not be easy, but we have some tips for that. And this is the zone 2 and zone 3. And for the stages, we look at the border of the vascular and avascular retina. And when we say stage 1, it is just a linear line, whitish linear line between the avascular and vascular retina. And when you see a little bit sprouts of neovascularization, it's stage 2. And when it's elevated in 3D, then it's stage 3. Stage 4 and 5 stands for retinal detachment. In stage 4, we have retinal detachment. If it involves macula, it's called stage 4B. If not involving the macula, it's stage 4A. And stage 5 is the total retinal detachment. And they also, in that first paper, they also defined the plus disease, which was very important. It's the increased dilatation and tortuosity of the vessels around the optic nerve head especially. It should be at least in 2 quadrants, and those patients, babies, usually have the pupil dilatation problem, and this is the most important progression sign of the disease. So you shouldn't miss this one. And then in the second paper of the committee, they described the cicatricial stage of the disease, and they defined the stage 4 and 5 in detail, and also the cicatricial stage as, you know, some peripheral avascular retina in cicatricial stage and some vitreoretinal changes, peripheral membranes, direct retina, direct macula, lattice-like degenerations in the periphery, and pigmentary degenerations in the retina. So those were the cicatricial changes. Then in 2005, like many years after that, like 20 years after the first one, again the ICROP committee come together to make the additional descriptions, and they published this paper. And if you don't have these papers, please check and please read these papers. They are very important. And they have described the zone 1 as a practical definition, and they also described pre-plus disease. I will explain it later. And also, very important, aggressive posterior ROP. These were the additions of the second ICROP committee. And they described that when you're checking the zone 1, it may be easy to see it in the temporal area because you can just see the distance between the disc and fovea, and you can just make it twice, and then you see where the zone 1. But in the nasal area, it may not be so easy. So just to make it easier, just use your lens, like 28 dioptry lens, place the edge of the lens to the nasal edge of the disc, and the other edge, the field, is zone 1. So this is a practical description of the zone 1. So even in nasal area, so you can understand where the zone 1 is. So when we look at this, so it's like this. So when you put the lens, it's there, zone 1. And also they describe the pre-plus disease. They have, in the first paper, they have described plus disease, and they put some representative pictures of plus disease. But there were some babies with dilatation of the vessels which doesn't fulfill the criteria of the plus disease, but they are already dilated. So in this paper they described those cases as pre-plus disease because it is another sign of progression. It may not fulfill the criteria of that picture. And they also described the aggressive posterior ROP, which was previously called as rush disease. You should examine it with 20 degrees to catch the details. And there will be one more talk by Ahmet Shafai to explain this aggressive ROP, but we know that there is no visible whitish ridge, typical classical ridge area. That's why it can be missed easily by an inexperienced examiner, and it doesn't follow stage 1, 2, 3, and it may jump into stage 4, 5 all in a sudden because it's an aggressive form of the disease. So you shouldn't miss this one. And it's in zone 1 or posterior zone 2 as described in this paper, and the plus disease is everywhere in whole quadrants, and there's flat neovascularization. Ridge is invisible as you see in these pictures, and there's rapid progression. When you see an aggressive posterior ROP, you have to treat as soon as possible. So this is, for example, an aggressive posterior ROP, and when you're not experienced enough, then this part, the choroidal vessels, may be thought like, they are retinal vessels. If the area is kind of not so clear, then it may be missed. But this is, for example, you see the whitish ridge area, whitish ridge, which is very typical. It's also a posterior disease, but this is type 1 ROP. So this type 1 stage 3 plus disease, but not an aggressive posterior ROP. They are different. So this was described in that paper, and then afterwards anti-VEGFs came to our life, thanks God, and it changed everything, as you know, with BTROP study, and it has so many positive sides, but there were some other sides, like we had never-ending visits because the disease, in most of them, peripheral retina never gets totally vascularized, and there are some late recurrences. So the first classifications then failed because we need some additional definitions for these babies. So after introduction of the anti-VEGF, and also we have some imaging, the new imaging devices. In the previous papers, there were some only narrow angle imaging devices, and patterns of ROP in some regions of the world do not fit neatly into the current classification systems. Like in the developing countries with low NICU conditions, we have some different kind of ROPs which are more aggressive than the other ones. So all of these just stimulated the ICROP 3 committee to come together in 2019. I was one of the members, and the paper came, and if you don't have the paper, you can download it with this QR code, and this is the most recent paper of ICROP 3. And in this paper they have redefined the zones as posterior zone 2, because we were talking about posterior zone 2, which is again a posterior disease, and it was defined in aggressive posterior ROP, but we don't have the practical definition of posterior zone 2. Now we have it, and it is, as Dr. Baran already told, it's zone 2 disc diameter anterior to zone 1. So when we check it here, when we put 2 disc diameters to zone 1, it is posterior zone 2. Okay. And then with those dashed lines, we have now zone 2 definitions. And we also described the notch issue, because we were having zone 1 disease, which was posterior disease and usually aggressive disease. But in some of them, we only have the zone 1 disease only in a small area, like 1-2 clock hours. So it's not the same as the whole area of zone 1. So since the vascularization pattern of the primates is a lobed pattern, it's not a circular but lobular pattern, that's why we have those notch areas. That's why this is called as zone 1 secondary to notch, for example. So we should describe it, because this is different than the standard zone 1 disease in all the quadrants. Okay, so this is better. This notch was defined in ICROP 3. And again, for the early stage of the vascularization, we have some avascular retina in premature babies, but there is no ridge, there is no formation of a line. So someone was saying stage 0, someone was saying immature retina or no ROP, but it should be also defined as, in this paper, it was stated that it should be defined as incomplete retinal vascularization in zone something, zone posterior, zone 2, zone 1, something. So it should also be described as incomplete retinal vascularization. This is the terminology. And these are the pictures from ICROP 3 for all the stages. And also in this paper, they have described that when we have flat neovascularization, which is usually the case in aggressive posterior ROP, it was not, normally stage 3. In stage 3, we have 3D neovascularization, which is elevated. But these are flat neovascularization in aggressive ROP. It's again neovascularization. So it should be accepted as stage 3. They stated this. And for stage 4, OCT pictures are added in ICROP 3. And in stage 5, we have subclassification of stage 5, A, B, C. This was stage 4 ROP cases, A and B. And in these cases, OCT pictures are added because sometimes you see retina is elevated, but sometimes it's not elevated, but only a retinoschisis. You say that it's stage 4, but actually it's stage 3 with some retinoschisis because of the traction. So OCT can discriminate these two conditions, and sometimes macula looks like it's attached, but when you check with the OCT, it's detached. So you discriminate between stage 4A and B by OCT. And for stage 5, we were previously calling it as total retinal detachment, but with some ultrasonography definitions like open funnel, closed funnel. But actually, these were not describing it very well, because OCT is not always very descriptive. Sometimes you see some membranes which act like retina, so it's very difficult to discriminate with ultrasonography only. So, and these are all stage 5, as you see, total retinal detachment, but this is with leukocoria, this is with corneal opacification, so they don't act similarly. That's why I was the one who suggested this subclassification. That's why we did a subclassification of stage 5. If there is a weave to posterior pole to optic disc, for example, it's called as stage 5A, and if you don't have any weave to posterior pole causing leukocoria, which is usually associated with closed funnel retinal detachment, not necessarily but usually, that's called stage 5B. And when you have anterior segment changes like shallowing of the anterior chamber depth and the corneal opacification, iridocorneal adhesions, then it's stage 5C. Okay, so it actually one comes after each other. And for the aggressive posterior ROP, the committee suggests a small difference, so small change, because there were some aggressive ROP cases which are not in the posterior pole only, although vascularization has come to the zone 2 or even to anterior zone 2, something just stimulated, and that cause very aggressive ROP, like systemic condition or very high oxygen saturations. So kind of oxygen-induced retinopathy things, which is usually present in low NICU conditions, which is not in good conditions. We can have some aggressive ROP, which is not too posterior. It was actually, called as aggressive posterior ROP in the previous paper. Now they call all of them together as aggressive ROP, not aggressive posterior, because it can happen in the anterior retina too. When you see like 3 branches here, like the right 3 branches, and you can see, although the retina is vascularized, you see neovascularization posterior to that, those vascularization areas. In such conditions, you should think about this aggressive ROP. And these are very typical appearances. They are very weak. If you have oh, that one. This one? Okay. Okay, this is better. So you see, it's like the right 3 branches. So you have capillary non-perfusion even posterior to the ridge, which is not the typical, the behavior of the ROP. So you usually induce it by low NICU conditions. That's why it's called not aggressive posterior ROP, but now after ICROP3 it's called aggressive ROP for all of those. And for the imaging, they have suggested some changes. It's very subjective. There are inter-observer variability, and there's good agreement at the ends of the spectrum only, even in the, very experienced ROP specialists. And the paper stated that the important thing is that the tempo of the disease is most important. And you can say pre-plus to this one, I can say plus, but the main thing is the tempo of the disease. If you see that in every visit, if the vascular dilatation is kind of increasing, then that means a very progressive disease. That's the tempo. All the factors like demographics, clinics, zone, progression rate should be taken into account. It's not only one thing. So just one looking at the picture in the normal and in the very highly plus disease, we may all agree. But in the spectrum in between those things, there is not much agreement. But don't worry about it. Just check the tempo of the disease. So this was given in wide angle pictures in ICROP3 as normal, pre-plus, and plus disease in serial pictures, just to compare with the patient. And in the regression group, there were some terminology used by different people, like involution, resolution, recurrence, persistence, something like that. So after this paper, they said that we should use just regression and reactivation terms. Regression could be spontaneous after laser or after anti-VEGF, or we can have reactivation. So these are the terminology we should use. We know the spontaneous regression signs. It can be thinning of the ridge, decrease in congestion, decrease in dilatation, anterior migration of the ridge, and leaving some vitreoretinal interface changes. Regression after anti-VEGF usually happens quite quickly, in few days, like 2-3 days after the injection. And regression of the plus disease especially starts very early. If you don't see any change in the first few days, then you should suspect about the, if the drug is in the eye or not. It may reflux, we are using very small amounts, so you should think of that. And it doesn't progress. Okay. In the second week, after the second week, we can have, after anti-VEGF, we can see some progression of the vascularization towards the periphery. Not during the first week, of course. Sometimes it never reaches to the ora serrata, and we can see such avascular retina in the periphery. And when you see tortuosity of the vessels, even after regression, please don't think that it's a plus disease. Tortuosity may stay after anti-VEGF treatment or after spontaneous regression. It's not a sign of active disease, okay? It may stay in most of them. And this was a 4-year-old baby after anti-VEGF treatment. You see the peripheral neovascularization and avascular retina, which is quite seen quite frequently, and we have published this data, and we have seen that almost 75% has some peripheral persistent avascular retina after anti-VEGF treatment to some extent. So persistent avascular retina is another sequela of ROP, and in the future life they usually turn into lattice degeneration, retinal thinning, vitreoretinal interface pathologies, and rhegmatogenous retinal detachment is quite common in ROP survives, probably because of this. And the ICROP 3 paper also described the crunch phenomenon after anti-VEGF. It's similar to diabetic retinopathy cases, the PDR cases. If the fibrotic component is too high, neovascularization will regress, but it will contract and it will cause tractional retinal detachment or retinoschisis. As you see here, injected, and then we have this contraction which causes tractional retinal detachment. So the main thing is that it shouldn't be, anti-VEGFs shouldn't be injected in the late phase when the fibrotic component started. So it should be injected in the correct time. And this is another one after anti-VEGF injection. These are from the ICROP 3 paper. And regression after laser starts later. You don't see any change in the first week. It's not like in anti-VEGF. It starts very early, but after laser, if you don't see any change in the first week, no progression, that means that you're doing well. Usually regression starts in the second week, and at the end of the second week you see the regression side, but the first week you see the neovascularization and ridge is still pink, reddish, so very active still. And this is the regression of the after laser. And what are the signs for progression to stage 4? Vitreosis, opacity over the ridge or optic nerve head area, vitreous hemorrhage, thickening of the ridge, plus disease in at least 2 quadrants, and you see these signs usually after 45 weeks, usually, if it's not an aggressive ROP. And also for reactivation, when you see an increased disease activity after partial or full regression, which it usually happens after anti-VEGF. If you do the laser, properly, it usually regress very well. But if you have some skip areas, of course, it may not regress. Some parts of the ridge may still continue to proliferate. You have to, complete all the lasered areas. But for anti-VEGF, after some time, you can have some reactivations. And when you have a reactivation, although we don't have a clear criteria when to treat, how to treat these eyes, but we should describe it as ICROP 3 with the zone and stage and plus disease, and the extent of the disease should be indicated for reactivation. And for example, in this case, it says reactivated stage 2, zone 2 with preplus, designated as this one. So it's a reactivated, but you should define the zone and stage also. And these are some reactivations. You see reactivations in the first primary ridge area and also in the secondary ridge area. And for the sequela, it was stated that it's a lifelong disease. and we should be aware of the persistent peripheral avascular retina. We should be aware of the late tractional retinal detachments because of the hyaloid contractions, exudative retinal detachments, late rhegmatogenous retinal detachments. So it should be a lifelong follow-up. Glaucoma is much more common, and this is to summarize the take-home messages of iCrop 3. And if you still want to take the picture of iCrop 3 paper, this is the download link. Thank you. So that's all I want to talk. Is Hayat is here? Oh, sorry. Okay, please. I think you were in the other room. Okay, please come and continue.